The Kanski lecture series Cornea and Refractive Surgery Part 2, and in this part we are going to discuss about the penetrating keratoplasty. I told you already that the penetrating keratoplasty, in which the diseased cornea is replaced by the host donor cornea, and penetrating is means all the layer full thickness cornea is being replaced, means all the layers of the cornea will be replaced. Penetrating keratoplasty component layer grafting of the cornea is increasingly utilized, but full thickness keratoplasty remains commonly performed and is the appropriate procedure for the disease involving all layers of the cornea. Key surgical points include, so basically now increasing advances is that you transplant a layer of the cornea into the host cornea, but still the penetrating keratoplasty is commonly used because it is usually easily performed. A common graft size is 7.5 millimeters. Smaller graft may lead to high astigmatism, and larger diameters are associated with an increasing tendency to peripheral anterior synecdoche formation and a raised IOP. So if the corneal graft is usually 7.5 mm, so what if it is smaller in size? If it is smaller in size, it will cause the astigmatism. And if it is in larger in size, it will cause the peripheral anterior synecdoche, and if the peripheral anterior synecdoches are formed, it can cause raised IOP. The donor button is usually 0.25 mm larger in diameter than the host site. So when you refine the donor cornea, you make it 0.25 mm larger. For example, if the host cornea is going to be you refine it 2.5 mm, 7.25 mm, you are going to take 7.5 mm of the donor cornea. Preparation of the donor cornea should always precede excision of the host tissue. In case a problem with the former means that the surgery cannot be completed. So this is because you should always, if the donor cornea, extract the donor cornea. If the donor cornea is not adequately refined, or there is some problem, then you can abort the procedure. But what if the host, you just refine the host cornea and you don't the donor cornea is defective, then you don't have any other piece to put it on the cornea, it can be a very problematic. Either mechanically guided, manual, or automated, including laser trephination, is commonly used. Basically, what is a trephine? Trephine is a basically instrument that is used to excise the cornea, whether it may be in the host cornea or in the donor cornea. So trephine is, you can say, it is a blade, and it is of certain diameters. Like if you are going to trephine a 7.25 mm cornea, then the trephine should be of that size, and you press it, and there are manual and the automated types. The graft may be secured with either continuous or interrupted suture techniques, or a combination of both. So there are two techniques to suture the cornea to the host cornea. It is basically, you can do either continuous and interrupted suture. So you can see figures 8.5, 8.3. We are seeing excision of the host tissue. So in this case, we are excising the host tissue. A is a partial thickness trephination. So this is a trephine that is put into the cornea, and you just rotate it, and it causes the partial thickness incision. Incision into the anterior chamber. B is showing that you are incising with a blade, or you can use a scissor with it to enter the anterior chamber, and C and D is the complete excision of the cornea. Now 4 is showing that fixation of the donor button. So this donor button is put onto the cornea, host cornea. Donor button is placed onto the viscoelastic. You put the viscoelastic in the anterior chamber, and you put the donor button, and you start doing suturing. Donor button is placed into the viscoelastic bed initial cardinal sutures, and D is showing the 8 interrupted suture in place. And you can see penetrating keratoplasty. So this is continuous sutures and this is the interrupted sutures. Post-operative management. So post-operative management is basically you are going to prevent the rejection in the cornea. So you have to use the steroid in these cases, and that should be orally or like that. Topical steroid, prednisolone acetate 1%, dexamethasone phosphate 0.1% are used to decrease the risk of immunological graft rejection. Initial administration is typically every 2 hours with gradual tapering depending on the likelihood of rejection and clinical progress. Long-term installation at low intensity such as once daily for a year or more is usual. So you have to give the steroid for the longer period of time to prevent any kind of rejection. Other immunosuppressants such as oral azathioprine and topical and systemic cyclosporine are usually reserved for the high-risk patient. So we give systemic immunosuppressant in a high-risk patient. Cycloplegia, homatropine 2% twice daily is typically used for 1 to 2 weeks. Oral acyclovir may be used in contents of a pre-existing herpes simplex keratitis to minimize the risk of recurrence. So if the cornea is scarred due to the herpes simplex virus, then you can give the prophylaxis oral acyclovir. Monitoring of the IOP applanation torometry is relatively unreliable, so measurement is commonly performed during the early post-operative period with a non-applanation method. So you do it with the non-contact torometry. Removal of suture is performed when the graft host junction has healed. This is often around 12 to 18 months, although in elderly it may take longer. Removal of the broken or loose suture should be performed as soon as identified, as this reduces the risk of graft rejection. So we remove the suture after 1 year to 1.5 years, and that may be because if there is some kind of loose suture, we can remove it early, and if there is a broken suture, we can also remove it early. In a patient with a corneal graft, broken or loose suture should be removed, as this reduces the risk of localized vascularization and graft rejection. Post-operative complications. So a person has been done a penetrating keratoplasty, but you don't know, but there are going to be the post-operative complications can happen. So there are early complications and late complications. Early complications include persistent epithelial defect, loose or protruding sutures, risk of infection, marked sterile reaction, papillary hypertrophy. So there are going to be infection, there can be a epithelial defect, and there can be the loose or broken suture. Wound leak can happen sometimes with a flat anterior chamber or iris prolapse, uveitis, elevation of intraocular pressure, traumatic graft rupture, cystoid macular edema, microbial keratitis, endophthalmitis, and rejection. A rare complication is a fixed dilated pupil, that is Uretz-Zavalia syndrome. Late complications include astigmatism, recurrence of the underlying disease, late wound dehiscence, retrocorneal membrane formation, glaucoma, rejection, and failure without rejection. So these are going to be the complications of the corneal graft. So you can see figure 8.6 and 7. So 6 can see the A is showing the protruding suture, and so this is a protruding suture. There is a broken suture within the stroma. So this is, I think, broken suture. 8.7 is showing the post-operative complication, traumatic graft rupture. So the graft has been ruptured and exclusion of the intraocular lens implant. B is showing microbial keratitis and C is showing endophthalmitis. So corneal graft rejection. So what is the rejection? So there is going to be the difference between the rejection and a failure. One thing you have to remember, what is rejection and what is failure. So failure, the rejection can be, the failure can be due to rejection as well. The rejection is basically an immunological process in which the immune mediated factor causes the rejection of the cornea, whereas failure of the graft means that graft can be failed due to number of reasons. It can be preoperative problems that can happen because the cornea is not adequately was adequately refined. There was a low endothelial count, or there can be infection that happened in the cornea. So these are some of the common problem that is the cause of failure, and rejection is one of the cause of the failure, but it is not failure. Rejection and failures are two different things. Corneal graft rejection, immunological rejection of any layer of the cornea can occur. Rejection of separate layers, endothelial, stromal, and epithelium, can occur in isolation, but typically a combination is present. Simple graft failure can occur in the absence of a rejection, although rejection is a common contributory factor. So basically, different layers of the cornea can become rejected, but usually in the penetrating keratoplasty, combination of everything is common. So that is why the laminar keratoplasty has the advantage, because when you transplant the single layer, you have an ability to prevent the rejection of the other layers as well. The risk of corneal graft rejection is increased significantly by the presence of the host stromal vascularization, as we have discussed earlier that this is a poor prognostic factor for the graft survival. Pathogenesis. The corneal graft is immunologically privileged with the absence of blood vessel and lymphatics and the presence of a relatively few antigen-presenting cells. Inflammation and neovascularization contribute to the loss of this privilege. Important predisposing factors for rejection include. So basically, if the host cornea has some kind of vascularization or immunological inflammation, it can cause the rejection of the cornea. So other mechanisms include eccentric or large graft over 8 mm in diameter, infection, particularly hepatic, glaucoma, previous keratoplasty. So these are common cases of the graft rejection. If the host becomes sensitized to the histocompatibility antigen present in the donor cornea, rejection may result. So basically, the donor cornea has histocompatibility antigen, and if the donor cornea becomes sensitized to that, it can cause the rejection. Human leukocyte antigen HLA managing has a small beneficial effect on graft survival. Gender incompatibility has recently emerged as an important risk factor for graft rejection and failure, whereas the cornea of a female donor can be used in either male or female recipient. The cornea of the male donor should not be allocated to the female receptors. So gender is something that could cause the failure. So female can give it to everyone, but the male cannot. Male cannot give it to everyone. Male can only give it to male. Symptoms are blurred vision, redness, photophobia, pain are typical. So what are the symptoms that a patient is having a corneal rejection? Patient will present you with the blurriness of vision. He will tell you that he have a redness, increased sensitivity to light and pain. But many cases are asymptomatic until rejection is established. The timing of onset is very variable, occurring from days to year after keratoplasty. Signs vary depending on the type of graft. Ciliary injection should be associated with anterior uveitis as an early manifestation. So what will happen? There will be the circumciliary congestion and there will be going to be the AC reaction. Uveitis is common. Epithelial rejection may be accompanied by an elevated line of abnormal epithelium in a quiet or mildly inflamed eye, occurring at an average of 3 months. So after 3 months, usually there will be the abnormal epithelial line. So these are rejection. Subepithelial rejection is characterized by the subepithelial infiltrate reminiscent of the adenoviral infection, Kretschmer spots on the donor cornea with a deeper edema and infiltrative opacification. So some of the things you have to remember: if there is a subepithelial rejection, there will be going to be the spots, like there will be spots which is called the Kretschmer spots, that are similar to the adenoviral, and they are usually with a small opacification and infiltration. Stromal rejection features deeper haze. It can be chronic or hyperacute, the latter in association with endothelial rejection. Endothelial rejection is characterized by the linear pattern of the KPs, keratic precipitates, coda-rose line, associated with an increased area of inflammation at the graft margin. Stromal edema is an indicative of endothelial failure. So whenever there is a stromal edema, you can see that there are going to be some of the endothelial rejection. So endothelial rejection is basically, you will see the KP's lines, that is called the coda-rose lines. So let's see figure 8.8 for that. So 8.A is showing the allograft rejection, A is showing the ciliary injection, B is showing elevated epithelial line in epithelial rejection, C is showing Kretschmer spot, and D is showing endothelial rejection with coda-rose line arrow, node intense peripheral vascularization. So what happened when there is an endothelial rejection? You have to manage it. Early intensive treatment greatly improves the likelihood of reversing the rejection. The most aggressive regime is generally required for endothelial rejection, followed in order of severity by the stromal, subepithelial, epithelial. Intraocular pressure monitoring is critical. So you have to treat it with aggressively. Any rejection should be treated aggressively based on the type. First endothelium, then stromal, then subepithelial, and then epithelium. Preservative-free topical steroid orally for 24 hours are the mainstay of treatment therapy. The frequency is reduced gradually over several weeks. Steroid ointment can be used at bedtime as the regime is tapered. High-risk patient can be maintained on the highest tolerated topical dose, for example, prednisolone HD-DATE 1% 4 times daily for an extended period. So you have to give orally steroid, and that can be tapered according to the response of the patient, and they are set on a prednisolone QID for a extended period. Topical cycloplegics, homoatropine 2% or atropine 1% once or twice daily. Topical cyclosporin 0.05% or 2% may be benefit, but the onset of action is delayed. So I think I told you earlier, the cyclosporin is a very good anti-immune, but it is basically has a late duration of onset. So that is why it is first the steroid is a mainstay of treatment. Systemic steroid oral prednisolone 1 mg per kg per day for 1 to 2 weeks with subsequent tapering if given within 8 days of onset. Intravenous methylprednisolone 500 mg daily for up to 3 days may be particularly effective, suppressing rejection and reducing the risk of further episodes. Subconjunctival steroid injection, for example, 0.5 ml of 4 mg per ml dexamethasone is sometimes used. Other systemic immunosuppressants such as cyclosporin, tacrolimus, or azathioprine can be considered. So basically, you can give steroid in a dose of 1 milligram per kg per day, and if a patient present within 8 days of rejection, then you can give IV methylprednisolone 500 mg for 3 days, and that is particularly effective. Differential diagnoses include graft failure, no inflammation, infective keratitis including fungal and herpetic uveitis, sterile suture reaction, raised IOP, and epithelial ingrowth. In a patient with acute corneal graft rejection, early intensive treatment greatly improves the likelihood of reversing the episodes of rejection. Now next is a superficial lamellar keratoplasty. Superficial lamellar keratoplasty, this involves partial thickness excision of the corneal epithelium and stroma so that endothelium and part of the deep stroma are left behind, as a bed for appropriately partial thickness donor cornea. The area grafted depends on the extent of the disease process to be addressed. So basically, as the name suggests, it is going to replace the superficial part of the cornea and superficial layer of the cornea. So what happens if, for example, if a patient having a disease in the interior part of the stroma, in some kind of dystrophy, then you can remove the epithelium and the stroma, and you can leave the rest of the stroma and endothelium intact, and you replace it with the only that layers of the cornea of the donor tissue. Indications include opacification of the superficial 1/3 of the corneal stroma not caused by potentially recurrent disease, marginal corneal thinning or infiltration as in recurrent pterygium, terine marginal degeneration, and limbal dermoid or other tumors. Localized thinning or desmatocele formation. So it can be used if there is some kind of marginal thinning. It can be used when there is a superficial 1/3 of the cornea is involved in the disease, and when there is a desmatocele formation. Deep anterior lamellar keratoplasty. So deep anterior lamellar keratoplasty is basically you dig into deep, like you remove all the part of the stroma up to the level of the descending membrane, almost. Deep anterior lamellar keratoplasty is a technique in which the corneal tissue is removed almost to the level of descending membrane. A theoretical advantage is the decreased risk of rejection because the endothelium, a major target for rejection, is not transplanted. The major technical difficulty lies in judging the depth of the corneal dissection as close as possible to the descending membrane without perforation, and if this is not achieved, the visual outcome may be compromised. So in this case, you try not to disrupt the descending membrane, because if you disrupt the descending membrane, then it is most likely going to be the full penetrating keratoplasty. Indication include disease involving the anterior 95% of the corneal thickness with normal endothelium and the absence of break or scars in the descending membrane, for example keratoconus, without a history of acute hydrops or superficial trauma. Chronic inflammatory disease such as atopic keratoconjunctivitis that carries an increased risk of graft rejection. So keratoplasty if there is no such history of acute hydrops or trauma. Advantages: no risk of endothelial rejection, although epithelial, epithelial stromal rejection may occur, less astigmatism, and a structurally stronger globe compared with the penetrating keratoplasty. Increased availability of the graft material since endothelial quality is irrelevant. Disadvantage: difficult and time consuming with high risk of perforation. Interface haze may limit the best final visual acuity. Post-operative management is similar to penetrating keratoplasty, except the lower intensity topical steroids are needed and sutures can be removed after 6 months. So you can remove it after 6 months, and there is going to be the graft host interface haze. Endothelial keratoplasty is basically when you replace with the endothelium of the diseased cornea with the donor cornea. And there are two types, DMAC and DSAC endothelial keratoplasty. So basically you remove only the endothelium. In a DMAC is basically you remove the descending membrane and endothelium only. But in a DSAC you remove some of the stroma, inferior stroma as well in case of a DSAC. Endothelial keratoplasty involves removal of the diseased endothelium along with the descending membrane through a corneoscleral or corneal incision. Folded donor tissue is introduced through the small 2.5 to 5 mm incision. Descending stripping, automated endothelial keratoplasty. DSAC uses an automated microkeratome to prepare the donor tissue and is currently the most commonly performed technique. A small amount of the posterior stromal thickness is transplanted along with descending membrane and endothelial. In descending membrane and endothelial keratoplasty, only the DM and endothelium are transplanted. So how you do the graft, you make a small incision in the cornea, you put the microtome, remove the endothelium and the descendant membrane, and put the donor cornea, folded donor cornea, through that incision. Because the graft is only 5 to 10 microns thick, it is difficult to handle. However, the grafts are able to attach to the host tissue with less unevenness, which lead to more rapid visual recovery. Visual outcome and lower rejection rates are achieved, but intraoperative complications are higher than DSAC. Indication include endothelial diseases such as Fuchs endothelial corneal dystrophy. Advantages include relatively little refractive chain and structurally more intact glow. Faster visual rehabilitation when penetrating keratoplasty suturing is minimized. Disadvantages: significant learning curve, specialized equipment is required, endothelial rejection can still occur. Endothelial keratoplasty results in a more rapid visual improvement and less risk of rejection than penetrating keratoplasty. So let's see figure 8.10. So 8.10 is showing the endothelial graft undergoing rejection. Now we are going to study about the limbal stem cell grafting. So limbus is basically, there is a area of the cornea and there is a sclera, and between them there is a limbus in which there is a palisades of Boget, and in which there is a corneal stem cells. Corneal stem cells important for the regeneration of the shedding epithelium. So whenever there is some kind of limbal stem cell deficiency, like in case of the cicatricial conjunctivitis, or in case of any scarring of this, like in chemical injury, they're going to be the limbal stem cell deficiency. So when there is a limbal stem cell deficiency, you do the limbal stem cell grafting. Stem cells are the undifferentiated cells that give rise to the differentiated cells that form tissue and organ. Tissue-specific stem cells are important for maintaining homeostasis and for tissue repair after injury. Corneal epithelium is constantly self-renewing and does so throughout the life. Progeny of the corneal stem cell divide and differentiate to form the basal corneal epithelial cells, transient amplifying cells that differentiate into wing cells, post-mitotic cells, and finally superficial squamous cell terminally differentiated cells. So you know that cornea has, epithelium has a basal cell layer, and then there are 2 to 3 layers of the wing cells, and there are 2 layers of the squamous cells, superficial squamous cells. So these are the basal cells are the transient amplifying cells, wing cells are mitotic cells, and squamous cells are terminally differentiated cells that shed after some time. Various techniques have been described to replenish the limbal stem cell population in patients with severe ocular disease and associated stem cell deficiency. These include transplantation of the limbal area of a limited site from the healthy fellow eye, complete limbal transplantation of a donor annulus, and ex vivo expansion by culture of either host or donor stem cells with subsequent transplantation. So multiple methods are used for the limbal stem cells. So basically you can use the fellow eye, healthy fellow eye limbus, and graft it into the diseased cornea, as in case of the chemical injury. You can also do, what can you do? You can take the stem cells and grow them in vivo, culture them. So you grow them in vivo, and then you culture them, and then you transplant into the diseased cornea. And other, you can use the donor cornea for limbus for the transplantation. In patients with the unilateral ocular involvement in Steven-Johnson syndrome and ocular cicatricial pemphigoid, donor tissue should not be taken from the unaffected eye autologous. So in this case, when there is bilateral involvement, you are not going to take the other eye for that. Signs of limbal stem cell deficiency include conjunctivalization of the cornea with goblet cell confirmed with confocal microscopy, impression cytology with acid skiff stain or monoclonal antibody against cytokeratin 19. So you are going to see that cornea is conjunctivized. Like you can see the goblet cells in it. And how can you confirm? You can confirm it by the different stains confocal microscopy, periodic escape, and monoclonal antibody against cytokeratin 19. Superficial and deep corneal vascularization, fibrovascular paleness, persistent epithelial defect, and scarring. So these are all the signs of the limbal stem cell deficiency. Algorithm for the surgical intervention for the limbal stem cell deficiency. All associated abnormalities, lids, conjunctiva, intraocular pressure should be treated first. When the visual excess is involved, sequential sector conjunctival epithelectomy should be considered with the sector limbal implant. So what happens that if there is a very conjunctivalization of the visual excess, then you remove that part of the conjunctiva or conjunctival epithelium on the cornea, and then you put on the limbal transplant. In total unilateral stem cell deficiency, autolimbal transplant is the procedure of choice. In a total bilateral stem cell deficiency, use of the allograft from a living related donor or cadaver donor is the only option. So when if there is a unilateral limbal stem cell deficiency, you can take the donor limbal cells from the other eye, but if the bilateral are involved, then you have to go for the cadaveric donor. Indications include congenital, for example, aniridia. This is very common question. In aniridia, there is a limbal stem cell deficiency. Traumatic, chemical burn and thermal burn, chronic inflammatory diseases such as Stevens-Johnson syndrome, ocular cicatricial pemphigoid, ocular surface malignancy, contact lens related pathology. Advantages include regeneration of the corneal surface epithelium, visual improvement and improved comfort. Disadvantages: autologous graft, conjunctivalization, filamentary keratitis, scarring of the donor eye. So these are all the disadvantages. And in allogenic graft, infection, especially in immunocompromised patient, and rejection. An important sign of the limbal stem cell deficiency is the colonization of the cornea with goblet cells detected with impression cytology. So that's it for the cornea and refractive surgery part 2. We will discuss the rest chapter in the next part. Thank you very much.